First and foremost, I want to thank everyone for joining Share It tonight for this special program. Tonight, we will be learning from Dr. DePersia, Dr. Ellman, and Dr. Spear about the impact of pregnancy and breastfeeding on breast cancer screening. We are grateful for tonight's webinar sponsors, Merck and CGen. It is thanks to their support that we are able to provide such informative and educational webinars. And we would also like to thank our community partners for this evening, North Shore University Health System and Midwest Center for Women's Healthcare. Just before we begin, a few housekeeping items. Today's webinar is being recorded and will be posted on Share It's website along with a transcript. Participants' faces and names will not be in the recording. That being said, if you would like to remain private this evening, you can turn off your video and rename yourself, or you can call into the webinar. The instructions are in the chat box now for both of those options. You may have noticed that all participants were muted upon entry this evening. Please keep yourself on mute throughout the call. If you have any questions for the doctors or for Share It, you can put them in the chat box, either publicly or click on Share It in the chat box to submit a private question. We have received many questions in advance of this evening, and we anticipate that many questions will come in through the chat box, and we will try our very best to answer all of those questions this evening, but any questions that are not answered by the doctors tonight will be addressed by email over the next week. We recommend that you keep your screen on speaker view. This will enable you to see the doctor's presentations, and you can find that option in the upper right-hand corner of your screen. As a reminder, Share It has been providing telehealth services to the breast and ovarian cancer communities for nearly 20 years, and the pandemic has not changed that. We are here for you, and we continue to be here for you each and every day. As we move into the webinar itself, I also want to remind you that Share It is a national not-for-profit support and education organization, and we do not provide any medical advice or perform any medical procedures. The information that was provided by Share It is not a substitute for any medical advice or treatment for a specific medical condition. You should not use this information to diagnose or treat a health problem. If you have any questions that are specific to your medical care, the doctors tonight may not be able to advise regarding specifics and would instead advise that you speak with your own medical provider. Always seek the advice of your physician or qualified health provider with any questions you may have regarding a medical condition. And now, this evening, we are so honored to be joined by three fabulous physicians, Dr. Allison DePersia, Dr. Carol Ellman, and Dr. Georgia Spear. Dr. DePersia is a medical oncologist specializing in clinical cancer genetics at North Shore University Health System's Mark Neiman Center for Personalized Medicine. Dr. DePersia is a member of the high-risk breast team at North Shore. Her research includes refining risk assessment and screening approaches for patients who may be at elevated risk of cancer. Dr. Spear is the chief of the Department of Breast Imaging at North Shore University Health System and clinical assistant professor of radiology at the University of Chicago's Pritzker School of Medicine. Dr. Spear is a passionate advocate for personalized breast cancer screening and inform patients of their breast density, screening options, and associated risk. Dr. Carol Ellman has been a board-certified OBGYN since 1995 and is affiliated with the North Shore University Health System as well. Dr. Ellman practices in obstetrics and gynecology at Midwest Center for Women's Healthcare in their Evanston and Glenview offices. And I would now like to welcome Dr. DePersia.
Can you help me share my screen? It says that it's been disabled. Okay. Okay, great. So my name is Dr. Allison DePersia, and I'm a physician who practices cancer genetics and high-risk screening. A lot of my practice is high-risk breast screening. I'm going to start off our talk this evening. So what we'll be talking about is what you need to know during pregnancy and beyond for breast cancer screening. I'll start by talking about breast cancer risk and high-risk screening in general. Dr. Ellman will talk about breast changes in pregnancy and lactation, and Dr. Spear will talk about current screening guidelines in pregnancy and lactation. at an age 40 years or less. So the goal of breast cancer risk assessment is to identify women at elevated risk of breast cancer and personalize their screening and risk reduction. Ways that we can personalize screening include modifying the age at which we initiate screening imaging, what imaging modalities are used, and then sometimes we may also consider medications or surgery to reduce breast cancer risk. So specifically, like I said, we know all women are at risk of breast cancer, but there are certain women who have a higher risk. And so trying to identify higher risk women, as these are often women who might start screening at a younger age, more during average ages when one might be pregnant or lactating. So high risk of breast cancer is typically thought about as a woman whose lifetime risk is greater than 20%. And that's when we can consider additional screening outside of our general screening protocols, which typically might involve mammogram and screening breast ultrasound. The average woman's lifetime risk, to put it in perspective, is about 12%. Factors that can influence one's risk include personal history factors, genetics, and family history. So briefly, personal history factors that might influence risk. So just thinking about one's near-term risk, as we get older, our risk of breast cancer in general in the near term increases. Like I said, the median age of breast cancer diagnosis is around age 63 in the US. Reproductive history can have an influence. So that means our lifetime endogenous hormones, so our lifetime estrogens. So when we start our period, when we stop our period, and also when we have our first children. Biopsy history, so sometimes having a history of a biopsy that has atypia or a high-risk lesion can influence our breast cancer risk. Breast density, we know, can influence the effectiveness of imaging, but also is linked to increased breast cancer risk. Radiation history, so women who've had therapeutic chest radiation potentially for cancer treatment or something like that, like Hodgkin's lymphoma, for example, may have an elevated risk. We know that weight can be linked to breast cancer risk, specifically being overweight when we're postmenopausal. Alcohol consumption, we know that excessive alcohol consumption is linked to increased breast cancer risk. And we know that hormone replacement can also be associated with increased risk. This is primarily thinking about postmenopausal hormone replacement therapy. Obviously, there are young women who may have had surgeries to reduce risk and might be on hormone replacement, and those are going to be different circumstances, certainly. So thinking about, now we thought about the personal risk factors, now thinking about specifically the genetics. So these are not necessarily modifiable, but these are the genetics that we're born with. So we know that 5 to 10% of cancers in general are related to an inherited mutation, and the same can be said for breast cancer specifically. When someone has an inherited mutation that's linked to an increased risk of cancer or breast cancer, that is called hereditary cancer syndrome. And so these are genes where we all have 2 copies of each of these genes in every cell in our body, and we're born with a mutation or a change in one of the copies that basically makes it so that our body can't protect us from cancer as well as we'd like, and therefore we have an increased risk. Carrying an inherited mutation linked to increased risk of breast cancer is not a breast cancer diagnosis. It just tells us that one's risk is elevated compared to the average woman's risk, and therefore we might think about specialized screening and risk management for that individual. This is just a screenshot to say that there are certain instances where we think about genetic testing or more suspicious for the possibility of someone carrying an inherited mutation. And so in general, things that we think about would be strong family history, women with younger diagnoses, women with many breast cancers in our family. Typically, this is information that is taken by one's primary care doctor, OBGYN, and if there are any factors that make us think that maybe there is an inherited risk, then genetic testing might be recommended. So like I said, 5 to 10% of breast cancers are due to an inherited mutation, and majority of those are BRCA1 and 2, but there are other genes as well. Currently, the National Comprehensive Cancer Network, which is one of the guidelines bodies that we use in oncology, lists 12 genes that are linked to inherited risk. So there are genes that have a moderate elevated risk and genes that have a high risk. Examples for moderate risk would be ATM or CHEK2. These are genes where the relative risk is 2 to 4-fold times that of the average woman. And high risk would be genes such as BRCA1 and 2, where the risk can be as much as 5 or greater times. What we know is that genetic testing does help us identify high-risk women, and certainly if we find an inherited mutation, that may often explain a strong family history of breast cancer, but that doesn't explain every family history of breast cancer. There are limitations to genetic testing, either because there are genes we haven't discovered and therefore we can't test them, or the technology doesn't allow us to identify changes in those genes linked to increased risk, or there may be changes in the gene and we don't know whether that change actually affects the gene's function or is associated with increased risk. And that's something called a variant of uncertain significance. So it's important to understand genetic testing results in the context of family history, and just recognize that a woman who doesn't carry an inherited mutation may still have a high risk, either due to personal risk factors or family history. I had sort of already touched on this, but things that we think about in a family history that would increase one's risk would be having a close first-degree relative with a history of breast cancer, having multiple female relatives who've had breast cancer, having a female relative who's had more than one breast cancer in her lifetime, or relatives with young diagnoses of breast cancer. And for women who do not have an inherited mutation, have a strong family history, or have personal risk factors, there are different models that one's physician could use to calculate empiric lifetime risk. And that lifetime risk estimate, once again, is what tells us whether that woman's risk is over that 20% threshold, which is usually what we use to think about someone being high risk or being eligible to consider additional screening modalities outside of the general screening recommendations. In general, high risk screening, like I said, due to either an inherited mutation that essentially causes one's lifetime risk to be greater than 20%, or due to empiric lifetime risk estimates, would include annual screening mammogram, the addition of considering annual breast MRI screening for someone who can't do MRI screening for various reasons, which we'll address certainly in pregnancy. For one, one can think about doing automated screening breast ultrasound, and then typically recommend a breast exam every 6 months with a physician. In general, for high-risk screening, as far as what age that screening starts, it can depend on a number of factors. So for someone who has a hereditary cancer syndrome, so if there's a specific gene mutation that's associated with increased risk, then that gene may dictate when the risk becomes elevated, and one might be recommended to start screening. If it's based on family history and someone who doesn't have an inherited mutation, then often the recommendation is to start at age 40 or 10 years younger than the youngest relative with a breast cancer diagnosis, whichever comes first. And typically, if that age is, if the family history has a young age of diagnosis and 10 years younger is going to be below age 30, then usually we might start MRI in one's 20s, but mammogram is typically recommended to start at age 30 for screening. And then another factor that can influence age at screening is someone who's at high risk due to therapeutic radiation to the chest, like a Hodgkin's lymphoma treatment history or something like that. Then the screening recommendations are typically 10 years after radiation therapy, but not typically before age 30. Just as an example of a screening protocol that we might use in general for high-risk populations, so thinking about BRCA1 and BRCA2 carriers, thinking about the breast cancer risk, typically what we recommend is a yearly MRI starting at age 25, addition of yearly mammogram starting at age 30, clinical breast exams, which would be an exam with a physician every 6 months. And then obviously there are options that one can consider and discuss with their physician from a risk reduction standpoint, which might include medications or risk-reducing surgery such as prophylactic mastectomy. And the reason that there's the asterisk next to the MRI is just to say that there is a family history of very young onset breast cancer relatives who've had breast cancer in their 20s, then it may be considered to start MRI earlier than age 25, and that would be a discussion between the patient and her providers. And so that covers my piece, talking about in general what makes someone high risk and the screening that we think about for the in general. Do I need to pass the baton?
Okay, I think I'm wondering if Eva's frozen. No, Eva, you're not frozen. Are we passing over to Dr. Ellman?
Yes, Dr. Ellman, if you can unmute.
Okay. Can you hear me okay now?
Yes.
Okay. I'm trying to share my screen, but I'm having trouble with that. Here we go. Okay, perfect. All right, so. And let's see. Can everybody see those slides? Perfect. My name is Carol Ellman. I'm a general OBGYN and clearly new to PowerPoints and Zoom, so I apologize. My role is to see patients for general OBGYN care and hopefully recognize people who are at increased risk for cancers and pass them on to Dr. DiPergia and Dr. Spear. Today, I'm going to talk about some of the changes in the breast that can occur in pregnancy and postpartum, and then talk about pregnancy-associated breast cancer. This was my favorite picture, so I had to include it. When a woman gets pregnant, often the first sign of it is not a change in shape in her abdomen, but a change in shape in her breasts. They can be sore, heavy, enlarged. They can become increasingly lumpy. There can be changes in the nipple. And these can be ongoing throughout the pregnancy and the postpartum, which can make it difficult to do a self-breast exam, and also difficult as a clinician to know what is an important change and what isn't an important change in terms of something like a breast cancer. I apologize for the very anatomic pictures, but this is a picture of the anatomy of the female breast, and I wanted to include it for a couple of reasons. Number one, we tend to think of the breast as round, and it's important to note that the breast tissue goes all the way up to below the clavicle, and even can wrap around the chest a little bit into the axillary line or the armpit. There is something called the axillary tail of Spence, and I did not come up with these names. I'll put that disclaimer in. And that is a tail of breast tissue that can actually occur in the armpit area of a woman that can become enlarged during pregnancy and during breastfeeding, which if a woman wasn't familiar with that can be quite surprising. The part of the slide where it shows the breast tissue from the side, I thought it was important to see that there are many ducts that come to the nipple, not just one. And at the end of them, almost spreading out like trees, are these lobules that help make the milk and then pass the milk through the ducts out through the nipple. And it's important to also notice that there's other tissue in the breast. The yellow tissue is fatty tissue, and the white kind of veiny tissue throughout is something called connective tissue, which helps support the breast and the surrounding tissues. This is also another very anatomic picture, I apologize, but this is just a quick overview of what happens to the breast when we go through puberty. And of course, all women can look different, and all women can look different even from one side to the other. But during the breast development actually begins in utero. During puberty is when the breast tissue really starts to mature and grow. The external appearance changes, the volume changes, and the internal parts of the breast change with the branching and the development of the lobes. It's interesting to note that the breast doesn't completely and fully mature until a woman is pregnant, and some of the hormones and changes in pregnancy can help the breast architecture and anatomy reach its final maturation. So, for instance, in a woman who opted out of having children, her breast tissue may never reach this final maturation stage. And finally, this picture, which I apologize also for because it can be a little funny looking, shows the progression to the fully differentiated breast with maximum branching of ducts. You can see the difference between the pregnant breast and the lactating breast, which can even increase more in size. And along with some of these physical changes, the nipples can be very sensitive and sometimes uncomfortable. The breast size can increase even 1 to 2 cup sizes for some women. The veins can become more prominent, which is what you're seeing toward the lactating sign, which can be very disturbing to a woman if she didn't know that that was happening. A couple of other things. So I like to think about this picture as, what do people call me about because they're worried? Not only do women call me because they're worried that the breast size is different, the texture feels different when they do a breast exam. They look in the mirror and the areola looks different. It can look darker. You can get bumps along the periphery of the areola called Montgomery's tubercles. There will not be a test on that name at the end, I promise. And that can alarm somebody if they're seeing bumps there. And women can get, again, these prominent veins. They can get stretch marks on the breast. These are all changes that I don't think we all knew we signed up for when we decided to have babies, but are very common and can occur. And then in terms of breastfeeding, after delivery, hormones in the body start to change. And women initially don't have a lot of milk in their breasts. They have a very concentrated solution called colostrum. And then over about 3 to 5 days postpartum, they develop their breast milk, which can make the breast extremely heavy, can make the skin of the breast feel warm, lumps in the tissue when you press. It can be very uncomfortable. You can leak milk even when you're not nursing. And you can go through a little bit of a dance between an initial undersupply followed by an oversupply, kind of then restituting back to the normal where you're producing enough milk for your baby. And again, all these changes for a lot of women going through this for the first time can be very alarming if they're not sure that these are normal. And this is the final picture I included because during lactation, the breasts, and during pregnancy and lactation, the breast can increase 2 to 3 times their size prior to that. The stretch marks, the veins can really be intense. The ligaments which support the breast can be loosened a little bit from the stretching. And then post-lactation, a lot of women feel that the breasts almost deflate and can sag or droop a little bit because of some of the stretching of the ligaments in the breast. And again, create differences in how the breasts feel if you're to do an exam or press on the breast tissue, which again is something that women need to know can be quite normal. I'm going to pivot a little bit and speak just a little bit about pregnancy-associated breast cancer. We talk about pregnancy-associated breast cancer as breast cancer that is diagnosed either in pregnancy or in the first year postpartum. Older definitions of pregnancy-associated breast cancer included women for the entire time they breastfed, but the current diagnosis includes women just through the first year postpartum, even if they continue to lactate beyond that. The incidence is about 1 in 3,000 women who are delivering a baby. The average age at diagnosis is about 32 to 38 years old. The BRCA mutations are overrepresented in this group. In fact, if you take women in their 30s who are diagnosed with pregnancy-associated breast cancer, almost a quarter of them, or 22%, will have a genetic mutation that's identified. Diagnosis. So just as I was trying to really point out, it can be very difficult to find a mass that you know is different than the usual things that can happen when a woman is pregnant and lactating. But palpation of a mass that doesn't go away, visible skin changes. Sometimes the skin can look thicker or orange, like or almost like orange peel skin, where it has that kind of raised appearance and thick appearance. And very, very rarely there is something called the milk rejection sign, where a baby may start to refuse to latch from the breast that the cancer may be in. So given all of the above, all the changes that occur in the breast, it's very common, unfortunately, to see delayed diagnosis in pregnancy-associated breast cancer. The ability to make the diagnosis can be quite difficult. It's very hard for women to really do a great self-breast exam. It can be hard as a clinician to really understand what we're feeling and is this normal or not normal. So it's important to make sure women know that just because they are pregnant, they still need to try to persist with their breast exams and pay attention to things that feel different. Couple of epidemiologic considerations for pregnancy-associated breast cancer. In general, as Dr. DiPergia alluded to, the rate of breast cancer is increasing. In the United States, a woman's lifetime risk of developing breast cancer is 1 in 8. Pregnancy-associated breast cancer is consistently in the top 2 diagnosed cancers in childbearing women. So it's important, especially in my profession, to not ignore a woman who feels she notices something new in her breast. Delayed childbearing is a phenomenon that's continuing to happen. The average age of marriage is going up. There are many economic factors related to that. There are many social factors, educational factors that play a role into that. And therefore, the average age of childbearing is delayed, both in general and also even in a marriage. The time from getting married to having the first baby has been becoming a longer interval over time. And we're also getting a better understanding of the various types of breast cancers. Most of the older studies really did not differentiate between the different types of breast cancer in terms of their hormone receptor status, and that can make a difference in how the incidence is affected and how the treatment is affected. There are some maternal factors that I'm going to go into real quickly in a moment. Maternal age of first birth, age of pregnancy when a woman gives birth, the number of pregnancies that result in delivery, and I'll explain exactly what that means, and then breastfeeding. So this is a little bit of a busy slide. I apologize. When I was looking at the literature and when I was talking to my non-physician friends, kind of the general understanding is having babies protects you from breast cancer. And interestingly, that is both true and not true. Maternal age less than 30 at first birth confers a relatively short-term increase in breast cancer risk, but a long-term decrease in breast cancer risk. So this fact surprised me. And this relatively short increase in breast cancer risk can be anywhere from 10 to 20 years, depending on the different studies. So that to me, short-term, but yes, that's a fairly long time. The earlier a woman is at her first birth, the sooner this increased risk seems to go away. Women who have their first child after 30 have a short-term increase in breast cancer risk that is never fully offset by a longer-term protective benefit. So you can imagine in women who are delaying childbirth past 30, they're losing out on their protective or fully losing out on their protective benefit from having a baby. And again, I'll explain the theories behind this in just a moment. And in general, women who have their first child before the age of 30 have a slightly higher risk of premenopausal breast cancer, but a significantly lower risk of postmenopausal breast cancer. And so the big question would be why? Why are these facts the way they are? And the answer is nobody really knows the answer. There are many theories. In one theory that seems to be the most commonly accepted theory, women, because the breast cells finish their maturation, when a woman is pregnant, the breast cells are finishing their maturation and growing rapidly at the same time. So the thought is that if there are any potential genetic mutations in that tissue, they're going to multiply, replicate, and then grow, and therefore increase that woman's risk that a cancer would develop. And therefore, the later a woman gets pregnant, the more mutations she may have accumulated, and therefore the higher risk she may have for developing a cancer. Some of the other factors, age of the pregnancy. So it seems that there is a protective effect to making it close to full term or full term, that pregnancies that deliver at or after 34 weeks seem to affect the risk of breast cancer. Again, both that initial increase, but then the secondary protective effect. Pregnancies that end in miscarriage or premature delivery before 34 weeks do not seem to affect the risk for breast cancer. Number of children, the data suggests that having more children may lower your lifetime risk for breast cancer. And this is thought probably due to less ovulatory events, so less periods, basically, less changes in hormone. And breastfeeding. So breastfeeding lowers the risk for breast cancer. There's a cumulative benefit across all pregnancies. So a woman's decrease in risk depends on all of the time she breastfed all of her children added together. And this seems to affect the incidence of all types of breast cancer, whereas some of the protective initial increase in risk and then decrease in risk in pregnancy can seem to be related more to hormone receptor positive breast cancers. This seems to be breastfeeding seems to affect the incidence of all types of breast cancers. This is my last slide, and I am happy to take, I realize that last part is quite involved, and I'm happy to take questions in the chat, and I'm going to turn it over to Dr. Spear.
You're muted.
Okay, welcome everyone. Good evening. I just wanted to thank Charlotte for the invitation to speak tonight, and I'm going to be following Dr. Ellman's presentation in speaking about what we look at as radiologists. So I'm a breast imaging radiologist, which is inside the breast. So we have then the added advantage of using technology and technologic advancements to go ahead and image the breast and look inside and detect breast cancer. So I'll be talking about breast cancer screening and specifically imaging the pregnant and lactating patient. And I'm going to go through some facts that I know we alluded to on prior presentations, but 1 in 8 women will be diagnosed with breast cancer in her lifetime. That's a very high prevalence. That really makes up 12% of women. And it's the most commonly diagnosed cancer in women. So it becomes really important for us to be able to screen effectively in women for breast cancer. It's also the second leading cause of death in women. And each year, it's estimated that over 220,000 women in the United States will be diagnosed with breast cancer, and unfortunately, more than 40,000 will die from breast cancer. Mammography is what we use as the gold standard for breast cancer screening, and there's been an evolution over time from 2D mammography to 3D mammography, which is the mainstay now for screening. And regular screening with mammography has been found to decrease mortality due to breast cancer by approximately 45%, making it a very important tool for us. So the mammogram is basically x-rays that penetrate the breast tissue. And here's just sort of a pictorial, descriptor talking about how we compress the breast in 2 different ways. We compress it obliquely and then horizontally. And we look at these images, which are called a screening mammogram, on these very high-powered computers. And we're able to actually 3-dimensionally even scroll through the breast tissue to evaluate for breast cancer. And that's what we do as radiologists. We know that sensitivity of mammography is decreased in women who have what we call dense breast tissue. And Dr. Ellman did a great job sort of describing what the contents of the breast include. We have the milk ducts that arborize from the nipple posteriorly in the breast. We have lobules. These are eventually going to carry that milk and extrude it through the nipple. We have fibrous tissue in the breast. We have fatty tissue. And when we talk about dense breast tissue, we talk about how much of that tissue in the breast in each woman is glandular or fibroglandular in nature, meaning that it contains more of that hormonally responsive milk ducts and lobular units, as opposed to just fatty tissue. So the more dense breast tissue a woman has, the higher the risk for developing breast cancer. And the prevalence of having dense breast tissue is 40%. So 40% of women that we screen have this type of tissue, and they are at an elevated risk for developing breast cancer. And it is thought that growth factors that are produced in the breast stroma are a cause for that. And the reason is because if you have more glandular tissue in the breast, that more fibrous, glandular and hormonal dependent tissue, the thought is that you can have a higher rate of mutation in that tissue, because that's the tissue where we see that breast cancer develops in. We also know that in women who are at high risk for breast cancer, as Dr. DePerja mentioned, who have a lifetime risk which is greater than or equal to 20%, those women for those women, mammography alone is just not enough. It's simply not enough for us to screen for breast cancer because they are at higher risk. And she talked about the risk factors that are important to assess in women. So if they have a first-degree relative who had breast cancer, or if they've had multiple prior biopsies, or what is the age at first menses, all of these risk factors get placed into a formula, and our high-risk clinics, our genetic counselors, and our breast surgeons can determine breast cancer risk. And if a woman is at high risk, meaning lifetime risk of greater than or equal to 20%, again, mammography is not going to be enough. So as I talked about breast density, I just wanted to give you a sort of pictorial, view of that. And basically from left to right, we have 4 women's breasts. And on the left, we have a woman who has very predominantly fatty tissue. And on the right, we have a woman who has predominantly glandular or fibroglandular or dense breast tissue. So what we know is that when a woman has more dense breast tissue, not only is she at a higher risk for developing breast cancer, but in those women, we also have more difficulty in detecting breast cancer mammographically. And again, mammography is the gold standard for breast cancer screening. So we want our technology to be useful to be able to detect those cancers. So if you think of looking up in clear skies, clear blue skies on a beautiful day, you can see through the sky. You can see every element. You can see the planes flying by, et cetera. When you look through a cloudy sky, it's very difficult to see through. So imagine dense breast tissue being a really cloudy sky and our having to find breast cancer in that type of tissue. It can be very challenging. So this is what we talked about, decreasing our sensitivity to detect breast cancer with mammography, and also breast density, increasing a woman's risk for developing breast cancer. And that confounds the patient's risk for developing cancer. So for example, if she has dense breast tissue and has a strong family history and her age at first menses was very young, or all of those things combined will be established in a formula, and that formula will give us that risk factor. And if it's greater than 20%, a woman is considered high risk. So what kind of imaging can we use if a woman has dense breast tissue? Well, there are so many new technologies, one of which is automated breast ultrasound, which is screening ultrasound. It helps us increase our cancer detection rate above and beyond mammography alone. And it also helps decrease recall rates in women. So if we add automated breast ultrasound, which is a screening ultrasound, to mammography, we can perform those tests on the same day on a patient, and the ultrasound can give us added information that may reduce our need to recall that patient for additional imaging. We use automated breast ultrasound in our practice. We've been using it for over 5 years with extremely high success, and predominantly in women who are not necessarily high risk, but women who are intermediate risk. So 15 to 20% lifetime risk, and dense breasted women. So those women that are, 40% of women can have dense breast tissue. So if you have dense breast tissue and you're of intermediate risk, mammography with automated breast ultrasound is a great solution to improve our cancer detection rates. But what else do we have? Well, we have MRI. And as Dr. DiPergia mentioned, in women who are considered to be high risk, the most effective screening is going to be to add MRI, which is our most sensitive modality, which involves going into sort of a tube structure. Contrast is injected through a vein. We image using magnetic resonance imaging, which is not, it's not the same as mammography, and it's not ultrasound, which uses sine waves, but it's magnetic resonance. And the picture on the bottom right shows an MRI, and you can see the vasculature really bright on an MRI, because what happens is when the contrast is injected, our breasts take up that contrast. You can see it in the vasculature. And if a woman has breast cancer, a lot of times that involves also developing more vessels to the tumor. And so it enhances or lightens up or brightens on the MRI, and we're able to detect cancer that way. So despite it being our most sensitive tool, why don't we use it on everybody? Well, we don't use it on everybody because each imaging study we use contributes significantly to our ability to detect breast cancer. And I'll give you some examples of that. So mammography is very good at detecting calcification. Calcification cannot be seen on ultrasound or MRI. So it's become the gold standard for screening, because not only can we detect cancer, but we can see calcifications, which can be a sign of early breast cancer. And a lot of times with an early breast cancer, such as ductal carcinoma in situ or DCIS, we don't have a lump or a mass that we can find. We only see the deposition of these little calcium specks that look like grains of sand on a mammogram. And when we see those, it can alert us to look at them a little closer, scrutinize them, and decide as to whether or not we need to bring that patient back for further evaluation, possible biopsy, to see if we can detect a very early form of breast cancer. So mammography is a crucial component of screening. Now, again, we talked about some limitations in women with dense breast tissue. So what can we add? We can add ultrasound, because that adds the ability to detect cancers above and beyond mammography alone. And then we can also add MRI in specific subsets of patients because of its increased sensitivity. MRI doesn't detect calcifications, but it is
I believe Dr. Spear may have frozen. We're going to give her a moment to try to come back. Okay. Oh. I'll wait to hear from Dr. DePersia, who I believe is on the phone.
Maybe we want to take some questions, if there are any, for Dr. Ellman or Dr. DePersia while we wait.
We can. Oh. So while we are waiting, we can perhaps answer some of the questions that have come in. Dr. Ellman, you had mentioned the increase or decrease in risk of breast cancer associated with breastfeeding. If one has a choice, should they choose to breastfeed when they have a baby, or if they are increased risk of breast cancer, should they perhaps choose, oh, well, maybe we will. My apologies, maybe we'll go back to Dr. Spear. Dr. Spear, you are muted.
Okay, can you guys hear me? I'm so sorry about that. I don't know what just happened. My whole Zoom shut down. So if I may, I was just talking about MRI, how it has a very high sensitivity for detecting breast cancer, but sometimes we can lose specificity. And the reason why is because in a woman's breast, when they have dense breast tissue or when they're lactating, when there's more vascularity in the breast, you can get leaky capillaries. And since we talked about that contrast being taken up by vessels, if you can imagine, you can get leaky capillaries and it can confound our ability to detect a breast cancer, which is also noted with enhancement in the breast. So we have to use everything in our armamentarium as imaging to be complementary and to be appropriately personalized for each woman's risk, so we can be most effective in detecting early breast cancer. So routine screening with mammography for average risk women begins at the age of 40. But if a woman is at higher risk, we're going to screen earlier and we're going to screen more often. And in about 2% of breast cancers that we see, women are going to have that BRCA1 and 2 mutation. And those women are considered very high risk. And again, those women, the recommendation is going to be to screen with mammography and MRI. And new technologies such as automated breast ultrasound, which is screening ultrasound that I mentioned, are being investigated to see if they're effective in adding to a patient's regimen for screening. In our particular practice, because we've had quite a bit of experience with screening ultrasound, we have attempted to screen with screening ultrasound along with mammography in women who are not only high risk, but have dense breast tissue to see that added value. But there has been no literature to support us doing this in a large scale at this time. And we need more studies to make that effective, that sort of determination. So what happens in pregnancy and during lactation? Dr. Allman did a great job describing the changes in the breast and what she would look for clinically in her practice. But we look for things inside the breast that are affected the same exact way. So the hormonal changes cause an increase in breast volume. We see more fibroglandular breast density in the breast. More vascularity occurs in the breast due to all the changes in the ductal elements and the tissue of the breast. And it can often mimic pathologic entities and obscure our mammographic findings. So it's so important for us to be very cautious when we're screening women who are either lactating or pregnant appropriately, because sometimes these hormonal changes can actually confuse the picture and make it more difficult for us to detect breast cancer. I want to also touch on the fact that imaging is generally safe for both the mother and the fetus. But the decision to screen using certain modalities is going to require our consideration of underlying risk factors so we can determine what is the most appropriate regimen for that patient's personalized risk. And when we talk about safety of imaging, ultrasound is considered an extremely safe tool in women who are pregnant or lactating. There's no ionizing radiation. So from that perspective, it's an extremely safe modality. And given the potential benefits of ultrasound, the American College of Radiology, which is where we reside as radiologists, we suggest that whole breast ultrasound as a supplemental screening in pregnant and lactating women can be used and can be very effective. And it can also be used in women who are at high risk, regardless of their age, and lactating women that are at an intermediate or high risk. So ultrasound can be a modality that's added into the imaging, regimen that's tailored to a woman for breast cancer screening. Mammography is also found to be safe during pregnancy and during lactation. There have been many studies sort of determining what the radiation dose is to the breast, and then what scatter radiation can penetrate the abdomen of the woman that we're screening, and how much of that radiation can be passed along to the fetus as it's growing. And so what was found is that as our technology changes in mammography, the radiation dose is so low, it's really equivalent to even 7 weeks of background radiation that we experience just living in our world. For pregnant women, it is even safer to use mammography as an imaging modality after 20 weeks when all the fetal organs have developed. So there's an even higher, sort of determination of safety after those first 20 weeks as well. And MRI has been noted to be very safe in lactating women. It's not recommended in pregnant patients. And the one reason why is not because of the magnetic resonance imaging or the magnet that actually penetrates the breast to give us that image, but it's not recommended in pregnant patients because there are unknown effects from the injection of contrast that we give, which is called gadolinium, and how that can accumulate in a growing fetus. So MRI, we would say, is safe in lactating women, but not necessarily recommended in pregnant women because of that contrast injection. And at this time, we don't have any MRI protocols that do not use contrast. So we require that contrast to see the cancer. So that's why the other modalities such as mammography and ultrasound become predominant in pregnant women. So very recently, in fact, this month, in the journal one of the largest journals for radiologists called the American Journal of Rankinology, there was a review article talking about imaging patient. And this is a really busy slide, but it breaks down a woman's risk level and their age. And then it breaks down further mammography, ultrasound, and MRI, and whether or not, due to the cumulative data that we have thus far, that particular modality may be recommended or not recommended, or can be considered in a specific patient's age, associated risk factor, and whether they are pregnant or lactating. So I broke it down in the next couple slides to sort of simplify it for us. So when we summarize screening based on risk, mammography is recommended in all pregnant and lactating women, regardless of risk for screening. And specifically, when you're talking about an average risk woman, we start screening at the age of 40 and we do it annually. In women who are at intermediate risk, there can be a recommendation that we start screening earlier. And for women that are high risk, we can begin mammographic screening at the age of 25 and up. And again, this would apply to pregnant women and lactating women, regardless of their risk level. And when we summarize ultrasound screening, again, it can be lactating women, regardless of their risk level for screening for breast cancer. And this just correlates with the ages again. So if you're at average risk, we recommended screening to begin at 40. And for intermediate risk, it can begin 30 and over. And for women who are at high risk, depending on, if they have a first degree relative, like a mother who was found to have breast cancer at the age of 30, for example, we can begin screening 10 years earlier at the age of 20 in her daughter. So that's how that determination was made. And then MRI. So let's summarize MRI. MRI can be considered in lactating women of average and intermediate risk at any age. And that's lactating women because we know there's no harm to the lactating breast to image it with MRI screening. The reality is the big job comes from us as radiologists, knowing what the changes of normal lactation would look like on MRI and trying to scrutinize them to be effective in our screening, to have a higher rate of sensitivity and specificity when we recall a patient with a particular possible abnormality. And then again, MRI would not be recommended in pregnant women due to the unknown effects on the fetus of the contrast that we would inject via IV. So now I'm going to sort of come up with a couple slides that are really questions. So a lot of patients may say, should I ask for an automated breast ultrasound? If you have dense breast tissue, your doctor may recommend supplemental screening with automated breast ultrasound in conjunction with your mammogram. And there are several states in the United States that now have reimbursement laws that are helping with insurance reimbursement for supplemental screening, Illinois being one of them. So in Illinois, I actually was very involved in legislative efforts to pass our dense breast notification law. So I helped pass that in our legislation, and that passed a few years ago. So all women in the state of Illinois are informed of their tissue type in their mammogram report. And then we further have reimbursement legislation in Illinois that states that if a woman has dense breast tissue, then screening supplementally with either ultrasound or MRI, depending on the case in that patient, is also reimbursed by insurance. So I think those are also really important factors for patients given the cost of medical care. So I would say, ask your doctor if this test might be right for you to be added in your particular screening regimen, and it can be very effective when utilized appropriately. And then somebody asked, do I need a mammogram and a breast MRI? Can I have one or the other? If mammography, confers some radiation dose and I'm worried about radiation, can I just have the MRI? And the answer to that question is no. And there are a couple of reasons for that. An MRI alone will not give you the best interpretation for breast cancer screening as it will with mammography in conjunction. And the reason is, again, mammography shows and depicts the breast tissue in a certain way that allows us to see ductal changes like calcification development and other changes in the breast like distortion that are very important for us to detect early breast cancer. So when you use mammography and MRI together, you get the advantage of both tests and an increase in cancer detection rates for us to be able to detect that cancer. And so what do we look for when we look for breast cancer on a mammogram? We look for masses, we look for calcifications, and here's sort of a little summary talking about how you cannot see calcifications on MRI or ultrasound. So imaging studies are complementary, and the standard is always to have a mammogram with the possible adjunctive ultrasound or MRI. And then here's a slide just showing a depiction of a woman getting an MRI and what it looks like when we look at it. Again, it's recommended for women who are at high risk for developing breast cancer. It has a very high sensitivity of detecting breast cancer. And there have been many literature studies showing that screening with mammography and MRI and alternating every 6 months is effective. But frankly, we know that both studies are producing a very wonderful effect for women who are at high risk for developing breast cancer. So we can perform them at the same time or alternating every 6 months. And that often depends on the physician that's caring for you, whether it's a surgeon or primary care physician, and they will make that determination, and they're both equally effective. So when can breast cancer screening resume after having a baby? Well, for women who are at high risk for developing breast cancer, mammography and ultrasound can be performed during pregnancy and during lactation. So you can be screened if you're at high risk for breast cancer while pregnant or lactating. And when can you resume screening with breast MRI after having a baby? Well, it would be safely performed postpartum. And our American College of Radiology guidelines state that contrast administration to the mother is actually considered safe for both the baby and the nursing mother. So passing along contrast in the milk is not an issue because of the way that contrast is metabolized in the body. And very little, if negligible amounts, actually make it into the milk ducts and into the milk. And so it is very safe for a woman to continue breastfeeding and getting an MRI after having that baby. So what should we do? Be proactive. And as we can summarize with Dr. Ellman as well, self-breast examination, having a clinical breast examination with your primary care physician is extremely important. Having a tailored imaging regimen to the level of your risk, which we now call personalized screening, is going to be very important. If you're confused about things like breast density and other adjunctive new technologies, I would urge you to talk to your doctor. Your doctor may recommend adding a supplemental screening ultrasound along with your mammogram yearly. And I want to thank everybody for your attention, and we welcome any questions.
Thank you so much to Dr. DiPergia, Dr. Ellman, and Dr. Spear. That was really insightful and so informative. We do have many questions that have come in. So I am going to start. Is there an indication to get screened for breast cancer in the year immediately after giving birth, regardless of age? So is that year postpartum a key time to screen?
So as I mentioned in the guidelines, it's a safe time to screen for women who are considered high risk for developing breast cancer. So if a woman is high risk, and we talked about not being able to receive that MRI while she's pregnant for that particular year, then the next year she can go ahead and proceed with getting a mammogram and MRI, and that would be postpartum. So I would say sticking to as close to the yearly regimen and tailored screening approach as possible would be recommended. Again, as the evidence has been accumulated in the past, we thought, because there are so many lactational changes in the breast, are we going to have more false positives? Are we going to be calling back more patients because of these lactational changes? And that was a concern because we definitely don't want to do more harm than good when we're screening. We don't want to do unnecessary biopsies or unnecessary imaging just because it is this way. But what we're finding is that it is so important that women who are at high risk be screened appropriately, that as long as we understand what the changes look like on imaging, that it is safe for a woman to proceed with mammography, with ultrasound, with MRI following having a baby, regardless of the fact that she's lactating, because some women will be nursing for years. And we definitely don't want to miss the chance of detecting an early breast cancer.
And a follow-up question to that, which is that and I don't know if this is in all hospital systems or cancer centers. But for one participant, when scheduling that, annual MRI that they're used to having, and they're asked if they are breastfeeding, and then we're told not to breastfeed after the MRI. But I believe in the presentation, you have mentioned that the contrast was safe for the baby. So can you give some insight on that?
Yes. So precautionary measure, a lot of times women will discard the breast milk for like 24 hours following an MRI or some like contrast injection. But what we have determined with evidence-based studies is that now the recommendation is based on what we know about the contrast and how it's metabolized through the body, that it is such a negligible amount that actually is going through that breast milk, and then and therefore it's considered to be safe. So the reality is the guidelines are telling us that it's safe to actually go ahead and resume nursing following having an MRI, and that is safe to do so.
Great, thank you. And then if somebody has been told that they have dense breast tissue, does pregnancy perhaps change that, or are dense breasts always dense even after pregnancy or breastfeeding?
That's a great question. So a lot of breast density is really genetic. It's sort of how we're made up. Each individual breast composition can look very different. 40% of women are going to have dense breast tissue. During pregnancy, due to the proliferation of the ductal elements of the breast, the lobules of the breast, you can have an increase in density. And that's going to be transient during pregnancy, and it should resolve and resume back to what the normal breast would look like after that. But now another question that I get very often is, does breast density change over time as we age? And in general, when we think about it, premenopausal women will have a certain amount of that glandular component of the breast. And oh no.
Oh no.
Uh-oh. Can you hear me?
Yes.
Oh, okay, perfect. I'm sorry about that. I don't know what's happening. But yes, as we age, you can have involution of that glandular tissue and more fatty replacement of the breast tissue. But it doesn't, every breast doesn't follow the textbook. There are 90-year-old women that we're screening that still have dense breast tissue when they've started with that. So it could be variable, and there's really not much we can do about it. Many women will say, many patients will come in to me and say, can I change my diet? Can I do something different to change my density so it's easier for mammograms to be more effective? And there's really nothing we can do about it. It's just the way we're made up. And, some women are fortunate enough to have that involution after menopause, and some women aren't, and it is what it is. But the reality that I think is really exciting within the field is that we have so many advancements in imaging technologies that have really progressed our ability to find early breast cancer. So we are finding that we're helping women with dense breast tissue by using these modalities like 3D mammography, automated breast ultrasound, MRI, and it's really helping that early cancer detection.
Thank you. And then we have some questions about what it means to have a first-degree relative who might increase one's own risk of breast cancer. So a couple of examples are, if somebody has a sister who had breast cancer, what does that mean not only for themselves, but then for their daughters? So that would be the nieces, of the sister. And then similarly, if a grandmother, somebody asked that if their mother-in-law had breast cancer, should their daughter be considered to have an increased risk?
Yeah, so having family members with breast cancer history does increase one's risk. The more closely related you are to someone, the more it impacts your risk, because the more you share your genetics. And so that's where those models that we talked about really come into hand, because everyone's history is different, whether it's one grandparent or grandmother, which would be a second-degree relative, maybe a cousin who's a third-degree relative. So everyone has sort of unique combinations of relatives who are affected. And what I'd say is really the more closely related you are, the more it would influence one's risk. And that's where seeing a specialist to have a cancer risk assessment, where one might use one of these models or recommend genetic testing to see whether there's an inherited mutation. Because in an instance where maybe there is an inherited mutation, like a BRCA mutation, the BRCA gene, BRCA1 or 2, if there's a family member who has a history and carries that mutation, then it really matters whether the individual who's looking at their own risk also carries mutation. Because if you don't carry that familial mutation, then you likely do not share the family cancer risk that is due to the mutation.
Great. And then some questions about breastfeeding that, there was Dr. Ellman had a discussion about whether breastfeeding could lower somebody's cancer risk, or perhaps whether it's raised in the short term, depending on age of pregnancy. should somebody with a perhaps the BRCA1 or 2 mutation or another known mutation choose not to breastfeed, or should they, specifically choose to breastfeed, knowing what those risks might be?
That's a great question. And I think the answer has changed over time. So I think before we really had the capability to do good imaging in pregnancy and breastfeeding, it was common to tell women at a significant risk for breast cancer to not lactate or to stop lactation in a short order in order to resume their own imaging for their own safety. But as the quality of our imaging has gotten better, we have moved away from that recommendation. So I would tell any woman to do what feels right for her, for the mother-baby pair, and to just add in the imaging and the follow-up as we would normally do, because you want the woman to get the benefits of lactation in terms of lowering her risk for breast cancer, but you also don't want to put her at risk for missing an early cancer.
Great. And then another question came in about if somebody has already had a double mastectomy or a single mastectomy, whether I suppose in the case of being a previvor or in the case of having cancer treatment, is it safe to get pregnant during, after surgery?
I don't know if you guys want to answer that, but I'd say from my perspective, absolutely. And what's very important to know is we are seeing more and more previvors come through as well as survivors come through and being comfortable enough to go ahead and get pregnant. And it is important for them to know that sometimes, despite having risk-reducing surgery or treatment, surgery is treatment, some women will still get some of the effects to the breast that they might have seen if they hadn't had that surgery. Like sometimes they can feel some tingling or sensitivity to the skin of the breast tissue. And it's very important for them to know that that can be quite normal. But we would absolutely counsel women that they should be able to have the family that they want to have.
Yeah. That's interesting. I didn't know that, Dr. Ellman, about the sensation. Certainly, we know risk-reducing surgery is excellent for risk reduction. It's greater than 95%. And so I always counsel women who I follow for high risk that they've had excellent risk reduction. It's not impossible to get breast cancer after risk-reducing surgery, but it's very uncommon. We don't typically do routine screening imaging, but we certainly can do diagnostic imaging if there's ever a concern. And we do recommend still having regular breast exams and raising any questions or concerns to a physician.
Great. And then one final question that came in is if somebody knows that they are planning to, well, hopefully get pregnant in their near future, should they get a sort of a baseline set of images going into that before pregnancy or breastfeeding, knowing that things might look different after they have gone through that process?
So from a high-risk perspective, I typically recommend that my high-risk patients have their breast imaging up to date going into conception planning or family planning. Obviously, we recognize that family planning doesn't always work out in the time course that we anticipate. And so it's not a perfect science by any means, but I think that it is appropriate for someone who's high risk and is due to be screening at an age where they're starting their family to have that updated screening going into the pregnancy, just so that if there were anything very early going on, obviously that's something we would want to know beforehand.
I would also add that if a woman is high risk to begin with, it can be very anxiety provoking to go through the changes in the breast. Mm. And so to come into a pregnancy with normal imaging, I think is very emotionally a good thing.
Absolutely. Wonderful. Thank you. I want to thank all three of our physicians this evening, Dr. DiPergia, Dr. Ellman, and Dr. Spear, for educating us. I know that you've answered so many questions for all of us, for myself personally, and I'm sure that all of our participants this evening feel more knowledgeable after hearing from all of you. I would like to ask everybody to take a brief moment to fill out our evaluation survey that's linked in the chat box now. Evaluations really do help us inform our future programming, so thank you for participating. And we'd love for you all to stay connected with Share It via social media, where we post about events like these, program updates, and fun ways to continue to get involved. And again, I do want to thank our sponsors for tonight, Merck and CGen. And for everybody on the webinar tonight, please never forget that Share It is here for you and for your loved ones during this time. Share It provides emotional support, mental health counseling, and other programs that are designed to help you navigate through your cancer experience. All are free, completely private, one-on-one, and our number is 866-474-2774. And you can also email us at clinicalstaff@shareshare.org, which is also in the chat box now. Our social workers and genetic counselors are available here for you, and you are our priority. So please never hesitate to reach out. We're all going to get through this together. Please also continue to check our website regularly for what topics and webinars are coming up. And you can access recordings and transcripts of all of our past webinars on our website. And the link is also in the chat this evening. And again, thank you to all of our doctors, and thank you for all of our participants, and have a great night.
Thank you.
Thank you.
Yeah.